Hi, my name is Dr. David Power. I'm an interventional cardiology fellow working out of the Mount Sinai Hospital in New York City. So our study examined five of the previously published randomized controlled trials from the Absorb clinical trial program, examining bioresorbable vascular scaffolds. So originally, these bioresorbable vascular scaffolds, or BVS, they were designed to improve laid outcomes compared to metallic stents. They work through various putative mechanisms. Ideally, the complete resorption of the vascular scaffold, which occurs around 3 years. It unconstrains the native epicardial coronary artery. It unjackets long lesion segments, allowing return of normal physiological function. And it also preserves coronary bypass targets, unjails covered side branches, and may even unlayer treated in-stent restenosis segments. So these were really the promises that were looking, sought after from the Absorb study examining these BVS. Really, the huge benefits of not having a permanent, lifelong metallic implant can't be understated. But it's important to remember that we were looking at a first-generation BVS device compared to fourth or fifth generation everolimus-eluting stent platforms. So the Absorb BVS is manufactured by Abbott Vascular, who are based out of California. It's a poly-L-lactic acid-based bioresorbable scaffold, which elutes everolimus. It's quite a thick strutted platform at 157 microns compared to contemporary stents these days, which are down to around 60 microns. Like I mentioned, has a bioresorbable scaffold. And after about 3 years, OCT studies have given us good information that the scaffold is fully absorbed by that stage. So I'll start with the study design first. So this was an individual patient data pooled analysis from 5 Absorb randomized trials. This was Absorb 2, Absorb Japan and China, and then Absorb 3 and Absorb 4. And this really encompassed the entirety of the Absorb BVS clinical trial program. All trials have complete follow-up up to 5 years, and they examined the outcomes of BVS before and after 3 years compared to a contemporary Xience stent. Overall, they enrolled just under 6,000 patients in 333 centers in North America, Europe, and Asia. And then we had very good clinical follow-up in about 90% of patients. So who were these patients? They were mainly males, about 75% male in their early 60s, about 1/3 had diabetes, 1/3 had prior PCI, and about 10% in both groups had renal dysfunction. In terms of presentation, about 2/3 had chronic coronary syndromes, and 1/3 presented with acute coronary syndromes, of about 10% of which were troponin positive MI. So encompassing a broad spectrum of patients here. The key bottom line finding was that the period of upfront risk with these bioresorbable stents, it ends at 3 years. So although through 5 years, these bioresorbable vascular scaffolds resulted in higher rates of TLF by about 2 to 3% compared with stents. After 3 years, between 3 and 5 years of follow-up, there was no significant difference between BVS and between the Xience everolimus-eluting stents. So initially, the poor outcomes associated with the Absorb BVS up to 3 years had originally been attributed to suboptimal mechanical properties and suboptimal techniques during implantation. A lot of patients would have both cultural and personal desirability of leaving nothing behind in the coronary arteries. And there's a lot of clinical benefits to that as well, which I mentioned earlier. So really improving the type of scaffold designs, reducing strut thickness down towards the level of contemporary DES, under 100 microns, and using intravascular imaging to implant these stents, which have a maximum post-dilation range of about 0.5 millimeters, can really push the whole field forward as a group. Similar to what I alluded to before, this was a first-generation bioresorbable scaffold going up against multi-generation drug-eluting stent with Xience. I really think lowering the strut thickness, iterating on the design, can both be used to improve the long-term and short-term outcomes of these platforms. In addition, longer dual antiplatelet therapy, potentially lasting up to 3 years, which is the time of the polyl lactic acid resorption. In addition to using intravascular imaging, approximately 20% of patients throughout the Absorb clinical trial program had intravascular imaging used to size these stents. So the majority were sized using angiography alone. And since they have such a close margin of error for post-dilation, up to 0.5 millimeters, truly it's potentially felt that using intravascular imaging, whether IVUS or OCT, to size the stent accurately prior to deployment would lead to a big benefit and potentially lead to equipoise during those first 3 years.